Hi, I'm Dr. Michael DeTola, and I'd like to welcome you to this clinical presentation on occlusal splints. Over the last 20 years of my career, the number of occlusal splints that I've done has gone up exponentially. In fact, Dr. Gordon Christensen estimates that nearly 1/3 of your patients are excellent candidates for occlusal splints based either on bruxism, clenching, or a post-restorative situation. So if you're an average dentist that has about 2,000 patients, this means that nearly 700 of your patients should currently be wearing occlusal splints. And if you're anything near the national average, your number is way lower than that. Keep in mind that there are 6 attorneys in the United States for every one dentist, and to a lot of these malpractice attorneys, the fact that a dentist doesn't even offer an occlusal splint to a patient who has advanced wear most likely would equate to supervised neglect. So why don't dentists make more splints for their patients? I didn't make very many splints for my patients early in my career because I did not like occlusal splints. And this goes back to the very first occlusal splint I ever wore, the one that was made for me in dental school by the student to my left. Now, there was nothing wrong with the splint. It was made exactly as the instructors told him to make it, but it was a large, maxillary, full hard splint. And when I would put the splint into place, teeth would move. Specifically, tooth number 10 would move. So every time I'd pop this splint in after not wearing it for a week or two, I could feel tooth number 10 being shoved back to the lingual. Little did I know I was doing Invisalign, instant orthodontics, and I wish I would have thought to patent it at the time. But because of the physiological movement of teeth, anytime you don't wear an occlusal splint for a couple weeks and pop it in, a tooth is going to move. And for me, it was painful. So now to wear my splint, I had to take 800 milligrams of ibuprofen just to be able to wear the splint. I did not make any splints for my patients because if I couldn't wear one, how were they going to wear one? A lot of the dentists that I talk to don't like to prescribe occlusal splints because they say they don't like to work with TMD patients. But that really represents a very small portion of the patients who I see that require or would benefit from an occlusal splint. 80% of my patients that I see that would benefit from an occlusal splint need a preventive splint, whereas only about 20% of the patients I see that could benefit from a splint need it for therapeutic reasons. Whether or not you decide to treat TMD patients is up to you, but there's still 80% of that third of the patients in your practice who can benefit from a preventive occlusal splint. In fact, the vast majority of patients that I make occlusal splints for fall into this preventive category. That is, we're just going to make a splint for them and not do any occlusal equilibration. In fact, when I think about the reasons why I do splints in my practice, most of them fall into the preventive category. So let's take a look at what some of these categories are. The first one is bruxism and clenching. Bruxism is defined as excessive wear in eccentric positions. I can certainly demonstrate that myself on my own cuspids and now my own bicuspids. Whereas clenching is defined as excessive wear in centric occlusion. And according to Dr. Gordon Christensen, 1 night of bruxism or clenching is equal to 100 days of normal wear. Doesn't it make sense to at least offer our patients a preventive therapy like an occlusal splint for those patients who brux or clench? The second reason that we make occlusal splints is for pre-rehabilitative purposes. This is going to be a patient who's probably going to have a full mouth rehab, has done some extensive damage to his dentition over the decades, and now in order to restore him from this collapsed bite, we're going to have to open him back up to be able to place some restorations on the anterior teeth. For this patient, we're going to make a splint that holds him open at this new vertical dimension of occlusion and see if he can handle being open again, see if his muscles will tolerate this new position. Once we find a measurement that's acceptable, we're going to use some Biotemps provisional restorations to hold him at this vertical dimension. The third reason to do an occlusal splint would be post-rehabilitation, that same patient we just mentioned, or another patient who gets, say, 20 units of bonded ceramic restorations. Any patient who has demonstrated wear before having these restorations done, and many times that's the reason we're doing these restorations, is going to get a post-rehabilitative occlusal splint. If the patient has worn down the teeth that God made, I certainly think they're going to be able to do a number to the teeth that this laboratory made. So we're going to help them ensure their $30,000, $40,000 investment, whatever it might be, with a post-rehabilitative occlusal splint. The fourth reason to do a splint would be for orthodontic reasons. There are some times where we're going to make a splint that's going to allow posterior teeth to erupt, for example, and able to open a bite that way if we're not doing a full mouth rehab on that patient. The fifth reason to do occlusal splints would be for periodontal purposes. If we want to splint teeth together and give them some strength and the patient can't tolerate having something like ribond or wire on the back of their teeth. And the sixth reason to do splints, and this would be in the therapeutic, not the preventive domain, would be for patients who are suffering from TMD. Again, you may or may not want to treat this group of TMD sufferers. I know dentists who say that all TMD patients are crazy. I know dentists who love treating this group because they love getting patients out of pain. Regardless of what you think about this group, it is somewhat comforting to note that 80% of TMD sufferers can be treated successfully with just an occlusal splint and an occlusal equilibration. However, the majority of occlusal splints that I make for my patients, in fact, the majority of occlusal splints that we as a lab make for dentists, are of the preventive nature. They are for bruxers, clenchers, and for post-rehabilitative situations. My favorite splint is a full maxillary splint. It's a hard, soft material. It's got a long, wide centric to give the patient some room, and it's got one occlusal stop for each opposing tooth. Now, why do I find that the hard, soft material is so important? Well, it's because I wouldn't expect the patient to wear an occlusal splint that I wouldn't wear. Remember that first splint I had back in dental school? It was so uncomfortable, I didn't make any splints for people because I knew it was too uncomfortable for even me to wear. The hard soft material represents an advancement in technology with these splints so that they're more comfortable to wear, especially if the patient doesn't wear it on a nightly basis. Now, we recommend that all patients wear these splints every night and during the day during periods of high psychological stress, but we know that's not always going to happen. So let's take our average patient who wears the splint when they have some soreness, when they wake up with either muscle sore or with teeth sore, and then they don't wear their splint for a week or two, and then they pop it back in again for the first time because they've woken up with some sore muscles. Now, if it's full hard splint, if they've had any tooth movement whatsoever, it's going to be very painful to put the splint in, and most of the patients I talk to say they literally get a headache from inserting the splint. On a hard soft splint, we have a 1/2 millimeter of soft material inside the splint. So if we have a tooth that has moved out towards the facial, this softer material will compress without moving the tooth nearly as much as the hard material. In fact, if you really have a tooth that's moved, either you or the patient can put a hard soft splint into some hot water and really soften that up and pop it back in again and let the softer material cool around the teeth in their new position. So let's go ahead and take a closer look at one of these hard soft occlusal splints and see what some of the desirable features for an occlusal splint are. This is what one of the hard soft splints, a Comfort HS for hard soft splints, looks like sitting on the model. Let's look at some of the desirable features of the splint. You can see that on the lingual, we've tried to thin this as much as possible. This is one of the most crucial aspects for patient comfort, is that the lingual flange of this splint be trimmed and be as thinned as much as possible to as much of a knife edge as possible, because really the clinical success of a splint like this basically comes down to whether or not the patient's going to wear it. When you have something that has this much retention as this splint does, you know, covering the buccal third of the cusps, these splints are not going to be able to be flicked out by the patient with their tongue during the night. And so really the splint is going to work if the patient wears it, and for the patient to wear it, it needs to be comfortable. So we want to make sure that this lingual flange material where it meets the palate is as absolutely thin as possible, not sharp obviously, but knife edged and rounded. Of course, with the opposing teeth, we're going to have one contact per opposing tooth on this splint in the posterior and in the anterior. And a little bit later in this DVD, we'll go ahead and seat one on a patient and check that to see how it fits. You can see we've got some anterior coverage here. We've got the incisal 1/3 of these teeth being covered. That's optional. You don't have to do that. It gives you some additional retention and a little bit extra coverage for those anterior teeth. But if you have a patient who needs to wear it during the daytime because they have a habit of clenching either on the phone or while driving, if they're a salesperson in their car, and they want to be able to wear it during the day, you can certainly grind or have the laboratory grind this away so that the acrylic material stops at the incisal edges of the anterior teeth. It does give you more retention to cover that, but there's plenty of retention on these splints anyway, as you'll see when you try one into a patient's mouth for the first time.